We appreciate you taking the time to attend today's presentation, Stage 2 Challenges and Plans for Success. Our speakers are Sharon Stewart from QHR Consulting Services and Kay Jackson from IATRIX Systems. Sharon has 30 years of information technology experience, which includes more than 25 years in the healthcare industry. As Senior IT Consultant with QHR Consulting Services, Sharon is responsible for client hospitals' IT and EMR assessments, development of IT strategic plans, vendor evaluations, selections, and system implementations. Her primary goal for QHR's IT consulting practice is to provide engagements that foster both enhanced utilization of existing IT systems and high-quality implementations of new systems. Kay Jackson has been in healthcare for over 37 years, from Director of Patient Access, Patient Financial Services, and Scheduling to consulting and working with vendors to create new solutions. Currently at IATRIX Systems, she is the Manager of Software Certification and Compliance, which includes working with hospitals on RAC and meaningful use. Now I will turn it over to Sharon.
Thank you, Amanda. I'm pleased to have the opportunity to talk with you today. We, as Amanda mentioned, have tried to work into the presentation responses to a lot of the questions you guys submitted with your registration, and thank you for that. Good news and bad news. Bad news was we didn't really find anything new. The good news was I think most of these topics are things we were already planning to tackle, just perhaps not in the depth that we're going to hit on them today. So let's dive right in. Here's the good news part of Stage 2. We know that we've been able to survive Stage 1 in most cases, and I'll make a mention here in a minute about people who actually haven't done that yet. That is a possibility. Some of the things that happened in this learning process are that we found out there are other things we have to buy. So some of the vendors that I work with have actually come up with solutions for problems, but those are requiring additional purchases, which is a little bit of a problem for us. Some of us have managed to capture some incentive payments. We've used this technology in places to save lives, and I'd like to dwell on that for just a second because that really is the purpose. Other than just being compliant with rules and regulations, people who use this technology effectively actually make a difference, a positive difference in people's lives. Some of the other things that we've done, we've annoyed a bunch of doctors, and we'll talk about that a little bit. Some of them we've actually made happy, but I think on balance we're still a tad bit on the annoyed side. And probably worst of all, one of the things that's happened is some of us have been audited. So here's a hint for you, and for those of you that have heard this already, I apologize for the replay. We ended up working with a hospital that was audited and actually lost their incentive payment. And they did so many things right in all of these clinical processes and workflows, but the thing that tripped them up was that they had their risk assessment done that they are required to get done, and they had plans to implement a remediation strategy, but they didn't have that documented, and they didn't document what they had actually done to try to remediate the problems that were found on the risk assessment. It's not that complicated. You don't want to document yourself into trouble and come up with a plan that you can't live with. And it was really frustrating, I think, for this facility because they had actually made capital purchases to try to help them close some of their security risk holes, but they really didn't get credit for that because they didn't have a formally documented plan. So there's a hint of what can happen. I can also tell you that there are a number of hospitals around who have been audited, and we're very successful with that. So congratulations to you if you're one of those places. That means that you did a good job of implementing your tools and you did a good job of documenting them. So now that we have all this additional knowledge, we're running a little bit scared. Our goal today is to help you be somewhat more prepared. We're going to spend a little bit of time talking about what happens if you actually miss and don't attest in 1 year. And then we're going to go into some more specific challenges and solutions for some of the challenges that we've seen people be successful with. So let's talk about the miss. Obviously, one of the things that happens if you miss is that you're either not going to capture your incentive payment, or in some cases you could actually lose some of the incentive payment that you've captured. We'll talk about that in a little bit more detail before we get off of this topic. The other thing that can happen if you miss, and if your miss is that you just didn't get your technology implemented, you can actually suffer patient harm from that. And that's a real shame. Some of these technologies, the barcoded MedAdmin, have been proven over and over again over the years to actually have a positive impact on the outcome for patients. And not being able to get that technology implemented can actually harm them. There are also cases where by not implementing things that we thought were extremely dangerous, that there's actually a patient benefit to that. So this really kind of falls under another topic, but I want to digress just a minute on that. I worked with a facility where the physicians that were most resistant to implementation of the electronic health record were in the emergency department. That's kind of unusual. I usually find them in other places, like surgery, yeah. Anyway, so here are the ED docs, and of course the first thing they did was send around a copy of their journal from their professional association that said that these electronic health records are dangerous. And, you know, of course, those came along with the, oh my gosh, we're going to harm our patients with this. I actually took the time to read that entire article, and I was relieved to see a couple of things. One is that the article was based on data. It was very well written, it was accurate, and the concerns that they raised were absolutely legitimate. The other thing that I was very pleased to see is that they finished up with a list of recommendations. I think there were either 8 or 9 of them, of things that emergency room physicians can and should do to help get the benefit from these systems and to help make them more safe. So we reviewed that information with the hospital leadership, with the emergency department leader, and went back to have another conversation with one physician at first and then the rest of the group to say, you know, your own professional association tells us that these are the ways that we can go about making sure that these systems don't harm your patient and in fact may actually help you provide a better outcome for them. How many of these are you willing to sign up and do? So it is possible to get there, but I really wanted to talk about that in terms of the miss, because I believe in most cases not getting this technology in place or not capturing the incentive dollars that help you fund this technology ultimately is not good for our patients. So back on the money side, critical access, I think we had a couple of questions that were specific to critical access. So there are a couple of things that I want to mention, and you may already be very aware of this. With the incentive payments for prospective payment hospitals, there's pretty much a formula that says you have this percentage of your population is Medicare or Medicaid, and if you hit the thresholds, here's how big your payment's going to be, and it's a fixed amount. Unfortunately, the process for critical access hospitals is hugely more complicated than that. Because these hospitals are cost reimbursed, the incentive payment is based on the allowable costs that you identify that were part of putting the system in place, purchasing it and putting the system in place. So immediately that's already far more complex, because now you're sitting there looking at page after page after page of line items saying, can we legitimately make the case that this cost, you know, maybe we had to put in a bunch more wireless access points in order to cover the third floor. Well, that's probably allowable. If you put in a bunch of wireless access points to cover the laundry, maybe not so much. So there are a lot of decisions that have to be made. So that's one thing that makes it more difficult for critical access. The second thing that makes it more challenging for critical access is the last year you can capture a payment is federal fiscal year 2015. The prospective payment, if you start a little bit later, you can actually run past that. So to the critical access folks, you've got to get it now. Get it in line and get it going. The other thing that you have to be very careful about is the timing of your expenditures. So the way this cost thing works is if you have a cost that's related to your electronic health record, and it occurs in 1 year, that you actually put it into service the following year and try to claim it on your incentive payment, they make you take a year of depreciation off of it before you actually get that incentive payment. So getting those years aligned, there's the federal fiscal year that tells you which part of the program you're in, and then there's your cost reporting year, which you have to get your expenses that you want to book for the incentive payments into that cost reporting year in order to capture them. So this is like a very complicated CFO thing. I'm not a CFO. But you really need to be very careful about where those expenses occur, and it's a really good idea to sit down with the details of those expenses and have them looked over and reviewed by an expert ahead of time to make sure that the things that are on your list for the incentive payments are actually going to qualify. So one final note, they are still costs, so you still get reimbursed for those costs, but what you lose is a 20% incremental incentive. And even with some of the smaller critical access hospitals that I've worked with, that is still a very large amount of money. So something to think about. The other thing I want to mention related to misses is Medicare versus Medicaid. The way the rules are written, if you miss a year under Medicaid, you can get back the next year. So if you're going to get payments over 3 years under Medicaid, because that's how your state's going to do it, you qualify in year 1. The next year you don't make it. The following year you can try for year 2 again and keep going from that perspective until you hit the cutoff date, which is way far out there for prospective payment. For Medicare, that's not the case. If you're entitled to 4 years worth of payments, if you get year 1, good for you. If you blow it on year 2, that's lost and gone forever. You can't get that back. So you need to really be paying attention. I think a lot of people are feeling some relief. I know a lot of people that we work with did their first year last year, so just had to have the 90-day reporting period. And then in federal fiscal 2014, those folks are able to actually just do a quarter worth of reporting again, so kind of had 2 easy years in a row. Not to say, pardon me, I didn't mean to imply that any of this was easy. Oh my goodness. But that is kind of a relief. For the people that are having to do full reporting years or who just came off of those that actually managed to qualify, we are very proud of you and congratulations. So there's a nutshell of what happens if you miss, both from a quality perspective, from a financial perspective, and from an accounting perspective and a timing perspective. If you have other questions about that, go ahead and put them in the chat box, and we will try to address them if we can at the end of the presentation. Because now we're going to talk about some of the challenges and the solutions that go along with those. Ta-da! They did a survey, and 30% of the hospitals that were surveyed felt like they had chosen the wrong EHR. And all of us feel that way sometimes. And sometimes it's warranted, and sometimes it's just a political thing that you get stuck in. And I have seen this happen where at some point in time, somebody blamed the system for something that the doctors didn't like, and you end up putting yourself in a place where you probably the only way you can succeed is by changing systems. And having come from the not-for-profit industry, I've actually seen that happen not just with systems, but actually with hospital leadership, where they know they have to do some hard things, and they send in a CEO that they know is only going to be there for a fairly short period of time, who basically does all the hard stuff and becomes the one that's the most hated, and then they bring in somebody after they've done all the cost-cutting and smooth the waters over. And so, honestly, I have to tell you that a large percentage of the system replacements that we do really are more political than not being able to work with the technology that they have. At this point, and we will probably hit on this again, but at this point, if you can succeed or live with what you have, you probably need to stay there. I am working on several system replacements right now, but most of those are getting ready to wrap up. And with us staring right up both barrels of ICD-10, trying to do that and change a system at the same time is just more than I would want to bite off, even with professional assistance. If you absolutely have to make a change, very carefully consider the timing of that. And since most of us now own physician practices, make sure that your strategy accommodates what your own physician practices and clinics are on as well. If you get one changed out and the other one doesn't make it across, you can end up with some substantial integration problems, which will ultimately cause you to have problems with transition of care and meaningful use. Next challenge, crummy physician workflow. So here's a quick trivia question for you. Some of you probably recognize the lady in the middle. If you don't, that is Regina Benjamin, who is our Surgeon General, and I have her here to represent physician leadership. Bad physician workflow is the problem. Part of the solution is good physician leadership. And you're never going to get yourself out of this until you get your physician population engaged. One of the things that we frequently help people do is go in and over time rebuild your order sets and your documentation templates. What happens is after, and I'm going to say it's going to take at least 6 months to a year, after your doctors have worked with these things for a while, you know, they start out and they want to make all these changes, and you may accommodate that or you may not. My recommendation is at the outset, I nearly said a vendor name, but there is one vendor that won't let you do that for at least 30 to 60 days, which is a good thing, until you understand how the system works. When you get from 6 months to a year, people begin to develop a sense of what can be done with the system, and that's when you really have to get after them to say, look, we bought this in part to make sure that we improve clinical outcomes for our patients. How can we improve the way we've got this system set up to actually do that? So improvement in care, and the other thing that you always want to be thinking about is elimination of waste, and that story plays very well with clinicians. If you go in and say we're going to save money, they kind of look at you funny, right? Or yeah. But if you go in and you say we're going to eliminate waste of materials, we're going to eliminate waste of your time, that's something that's really compelling to them that makes sense in the way they actually practice and deliver care. So if you have bad physician workflow, you've got to start with physician leadership, and you've got to have good physician governance. And we've set this up several different ways. A lot of it really depends on the size of your facility. So I've seen multi-hospital systems have a committee of, you know, a core group of 7 or 8 physicians with another maybe 8 or 9 that are truly functioning on subcommittees, and this is their whole job, is to make sure that the electronic health records that they use are actually providing a quality experience for the patients and for the people that provide their care. Smaller facilities, a lot of times I'll see a leadership committee that's actually composed of a couple of physicians and the hospital leaders, CEO, CNO, COO, those kinds of roles, so that they meet on a regular basis and they have an agenda, and part of that agenda is dedicated to addressing issues with the electronic health record. One of the things that I think you absolutely have to have is that you need to have physicians identified who are responsible for vetting and approving or rejecting requests for changes to your content, both in your order sets and in your documentation templates. A lot of us have made different decisions. Some of us have fought the hard fight and said everybody in OB is going to practice the same way. Some of us have said we're not fighting that, it's taking too long, everybody gets their own. Regardless of which way you came out, you're going to have requests for changes. And generally those requests for changes are going to come in a lot faster than you have capacity to address them. What you need are physician leaders who are responsible for being the official receivers of those requests, and they need to understand that they have a time budget. And, you know, basically we can update, every 2 weeks we can update 3 order sets and 2 documentation templates, or 1 of each, or whatever your number is that you agree on. And then those physicians have to make the decisions for the organization about which ones go first and which ones are going to be completely rejected. And then with help from your CEO, they need to be the ones going back to the physicians who are requesting the changes to say, we have these concerns about this, or we really like your idea. Here are the other things that are in the queue ahead of this, and here's about when we think this is going to happen. And that's not a fun conversation to have, but that's a reality of the way this thing works. So physician leadership and physician ownership of selecting changes. I actually saw one place, and it was for their clinics, not for the hospital, where the person who physically did the changes was one of the physicians. And that worked out pretty well from the IT perspective, because when people had complaints about how fast that was helping, they went and complained to the doctor. I don't know that I would really support that model. I'm just saying it's something we've seen out there that could possibly work for you. The process for people to request these changes and get them processed and get them communicated back out has to be simple. So not only do you need to simplify your physician's workflow and how they go about doing their daily business interacting with the computer, but the governance and the process of requesting changes to how that works have to be simplified. You got to have some guidelines, and by and large, the first one always has to be quality first and a good experience for the patients. Two other things that I'll mention on this, and then we're going to move very quickly through the rest of the material. But I thought that this is one of the most important things for us to address today. You need to make sure that you have adequate staff to do maintenance for your order sets and for your documentation templates, and to support your physicians for your CPOE implementation. Most of us have done CPOE implementations by this point in time, but a lot of them were very limited in scope. It was either just our hospitalist or only in the ED or so on and so forth. With stage 2, and we'll talk about this again in a minute, we know that that's basically going house-wide. And I'm just going to tell you that I'm aware of 2 critical access hospitals, and busy for critical access, but small hospitals nonetheless. Both of them ended up hiring 5 assistants who staff around the clock, and their whole job and their only job is to help physicians when they call for help with the system. And I know. So if you're the person that ends up having to go in and explain why you need budget for that and why that's in the best interest of the organization and their patients, and you need professional help for that, give us a call and we can consult with you on that. Sometimes that message comes across better from an external party who's actually seen it happen in other places. But what happens with a lot of CEOs is, okay, well, we did CPOE last month. We're over with that. Well, no, you know, the hard stuff actually happens after that. And you really do, depending on the size of your organization, you really do need that around-the-clock staffing. And you need it at least for 6 months, probably more than that. One place that I worked with has had pretty good success with hiring people from local nursing schools, students that are interested in having work and being able to do shift work and those sorts of things and work their school schedule around it. The thing you have to watch out for is it's really easy when somebody comes along with, oh, we need to take care of XYZ project. Oh, well, we'll just give it to this person. They have downtime periodically. You're much better off getting your elbows out and protecting those people and making sure that they have no responsibilities other than jumping when one of their physicians says jump and that I need some help. And that's either going to be by phone or physically in the hospital. And with the rest of the time, I'm just going to say that what I like to see them authorized to do if they're students is they can just use that time to study. So bad physician workflow, great big topic, you know, adoption, but just to kind of recap, physician leadership, revisit your order sets and your documentation templates, simple process for governance to receive and approve changes, but that's got to be formal. Make sure that you've got enough staff to support your physicians who are using the system and enough staff to actually make the changes that everyone agrees need to be made. So our next challenge, bad nursing workflow. What do you do about that? Some of the simpler things here, or similar things to CPOE and physician workflow problems, it's usually a good idea to really consider a redesign. Over the years with nurses and using these systems, we see people go through phases where they basically automate their paper process. And then the next thing that happens is they come through and they go, well, that was just really inefficient. We're going to take advantage of the system. We're going to rely on people's professional practice to know what they need to document and really simplify things. And in some cases, they overdo it. What I'm going to suggest is, as you're building these things, the number one mistake that people make with nursing solutions is they get all focused on capturing data and don't think about getting it back out. And the slide says data recovery like a technical thing. That's not what I'm talking about. What I'm talking about is when a nurse needs information in order to do their job and in order to deliver great, excellent patient care, what do they need to see in the system when they go to look? Do they have to go to like 5 different places to get a patient's story? Because the nursing notes are in one place, the lab results are somewhere else, the radiology information is somewhere else, and the physician orders are who the heck knows where. Be very mindful when you get a chance to do a redesign like this to think about how nurses need to retrieve information, not just how they have to put it in. One other thing that I'll mention that I've seen, sometimes you have to go to a third party to get a solution. It's a little bit crazy, but it's how it works. Worked with a hospital, and they have a telepharmacy for off-hours pharmacist coverage, which works fine right now because right now they fax or scan all of their med orders down to the pharmacy. Well, as they began to go onto CPOE, those things are no longer faxed and scanned by nurses. They're touched by the physician, and then during regular hours, the pharmacist sitting in the pharmacy is actually watching that queue, sees the order pop up, and processes it. And they have a policy where if a physician puts in a stat, they have to call and tell the people on the nursing unit that they've got a stat. So if you don't have a policy for that, think about it ahead of time. But after hours, how does the telepharmacy company know that they've got a new order? Because the way that model is efficient is they have one person responsible for 20 or 30 different hospitals for processing orders, and they can't physically watch all of those queues, so they have to have some kind of a tickle notification that says, hey, we've got one over here, go check our queue, or hey, we got one over there. And the way they used to do that was this fax would also send a copy to the telepharmacy company to let them know that there was something there they needed to process. Well, come to find out, some of our vendors, and not the one that I think most of you guys are using, but some of them really don't have the ability to spill off a transaction from a CPOE med order. It just goes to the pharmacy queue, and the vendor dug their heels in and said, no, you know, you guys are going to have to, they're just going to have to watch the queue. And it's like, well, we found a telepharmacy vendor that would do that, but they were so expensive that they might as well, the hospital might as well just hired another pharmacist. That really didn't make any sense. And the solution was to go to a third-party company who was able to actually monitor the database and see when one of those orders was generated and send a fax message to the telepharmacy company, not with the details for the patient or the medication, but just to say, go check our hospital's queue. There's a new order in there. So, and that wasn't a bad solution for them. So nursing workflow, redesign. If you have a problem where your systems aren't perfectly connected, think about a third-party solution. Just make sure if you do the third-party solution that you provide for having maintenance done. Okay. One of the questions that came in was what was most difficult, and Kay and I both looked at this, and at the same time we said, oh, that's obviously, and we came up with 2 different things. But I think we both agree. These are 1 and 2, CPOE and the clinical quality measures. We've talked pretty extensively about CPOE and the burden of that. One of the specific questions that came in was what was the impact of the higher CPOE percentage? And to me, the biggest impact of that is you can't skip your hard areas. Pretty much everybody has to be included. A lot of people skipped OB because we have a different solution in OB, and we were letting the physicians put their stuff on paper or putting it into the OB system. That doesn't work. They're going to have to use CPOE in the primary system because that's where the formulary is, that's where all the medication checks are. If somebody else has found another solution for that, send me a message. I'd like to know what it is. So we've had to tackle that because now what we've done is we've got these poor physicians. It's just as bad as being half computerized and half on paper, pretty much, as we've got them in two different systems to look at the strips and the progress of labor documentation, and then they're actually doing their orders and their notes somewhere else. I can tell you just a personal anecdote. It's not all that bad. One of my kids is a certified nurse midwife, and she's been working like that for years. She did her clinicals here in Nashville, now works in another part of the country. And she's like, yeah, I just use two systems. It's not perfect, but I know where things are. So to her, it's just like flipping from one screen to another within an application. It just happens to be two different things. So don't let them buffalo you on that. You can actually get across that. Let's see. There was another question. There was a question about the impact in the change in the way the medication orders were counted. I've not run into anybody that's really had a problem with that, and that change also applies to the stage 1 folks, where before it was one order. Your population were all your patients who had at least one medication order, and of those, how many of those had at least one order entered by CPOE to hit the stage 1 percentage, which was 30%, and I guess in stage 2, ooh, I should have written that down. I shouldn't try to remember these things, but it's a lot more. It's 60 to 80. And the change they made was optional at first, and I think it's going to be required in federal fiscal 2014 to take your total number of med orders and then just that percentage of them, either 30% or 60%, depending on which stage you're in, has to go in through CPOE. And I haven't seen that really making a difference because it's not any harder than it would have been before. The fact that the percentage is going up is harder because that means you've got to capture a lot larger part of your patient population. But in terms of it being more difficult than the other counting method, not really, because I've not ever seen a situation, I saw one place try it and it didn't work very well, where they put some of their orders into the computer but not the others. Years and years ago, some folks in Utah did an experiment where only the med orders went into a separate computer system for a safety check, and they did that. But in practical terms, you're either putting them in or you're not. If you have exception situations for codes and that sort of thing, you just find a way to deal with that. But there's not enough of that to really blow you off of your numbers if your physicians are all participating like they should. Clinical quality measures, and I didn't talk about that as much as I probably should. Some of the critical access hospitals are struggling because the things that they're actually able to capture, they don't have enough volume to actually use those measures. What my best advice to you is to actually run the measures, look at the data, and see how they're coming out of your system. Most of the vendors that I have worked with, well, let me rephrase that. All of the vendors that I have worked with are somewhat inflexible on how you can go about capturing these things, and that's created some difficulties for us. For example, one of the things that we know we do really well is pre-op antibiotic, but the system that we're using doesn't do that very well because the pre-op orders have to come in on paper because they can't put in orders on patients that aren't in a bed yet. And the only way the meaningful use report in that system captures a med order is if it came in through CPOE and got processed through MedAdmin. We're also not using barcoded MedAdmin in the OR. So, you know, it was unfortunate. That was something that they could have done, but they couldn't do those measures because they weren't capturing enough to even do any good. Ended up having to use an AMI measure, and this hospital, if somebody really is an AMI, is going to the other hospital that's 20 miles or 30 miles down the road because it's a larger facility. I acknowledge that struggle. There are people available who can help you with that. Let us know if you want somebody to contact you about engaging to help you with that. Selecting them is tough. Once you get the system set up, the other hard part of the clinical quality measures is training your clinical staff to collect the data that you need. And it's always easy from a technical perspective to say, oh, we'll just make that field required. But I avoid required fields like the plague because I think that they're disruptive to the clinical process. You really have to rely on people's commitment to professional practice, and their manager's ability to go to them and say, this is part of your job and you have to do it. So most difficult, there's our answer, these two things. We talked about selecting clinical quality measures. Reuse what you have if you're already capturing data for core measures. You're going to have to use, and I mentioned this already, you're going to have to use your vendor-supplied mechanisms to capture those. So these things are very closely tied in with the rules. In a lot of cases, you kind of have a menu of things that your vendor can support. Try to choose the ones that are most relevant to your patient population. And here's what to do when you have to convince your clinical staff that they have more data that they're going to have to capture, because clinical quality measures on a day-to-day basis don't do anything for them. And you can talk to them all day long about how this is going to help overall with your patients, and they're like, it's not helping this patient that's in front of me that I had to document this extra data. I like the little good for you, good for me picture. To the doctors, it's a benefit to your patient for us to capture this data. It will ultimately allow us to provide better care for them. That usually works on them. Also, you can sell it as a benefit to your colleagues. Doc, if you get this in here, the one downstream in the care process is actually going to electronically get this record now, and if this data is in here, they're going to make better decisions for this patient, and you're going to get a better outcome. And finally, something that's kind of uncomfortable for me, but I've had a lot of extremely successful and fabulous nurse leaders tell me that sometimes with nurses, the best thing to do is say, this is part of the requirements, just do it. So keep calm and just do it is sometimes a solution for nursing. I wouldn't recommend doing that a whole lot, but sometimes that really is the right solution. Just a note about selecting rules, there are some academic papers out there on how you can use your data to pick the ones that you want to pick. My best advice to you is use the data to find out what you can actually qualify for. Get it down to a short list of things that you would be happy to implement any of those rules, and then give it to your clinicians to select. And let them kick that around and decide what they think of the things that are available are the best ones to do for your patient population and your organization. That's going to help you a lot with the buy-in. And as long as you make sure you only give them choices that you can live with, that's not going to make your life any more difficult technically. One of the things I want to warn you about is, depending on your pharmacist, sometimes you can get a hold of these super intelligent and really detailed-oriented pharmacists, and they're going to try to get you to alert on every darn thing with your doctors. Don't do it. If you've already done it, I'm sorry. I hope you survived the experience. And if you're thinking about doing it and you need some assistance in convincing people that that's not a good idea, let us know, because you really can't do things that are disruptive to physicians. It really does adversely impact the care. And I appreciate that pharmacists want to do that, but it's something that's practical for them to do in the pharmacy, not so practical for a doctor who's standing there in front of a patient, a family member. We got questions about transition of care, some very specific, and I'm going to try to trip right on through these. Direct email addresses, where do you get them? My answer to that is to call Kay and our friends over at IATRIC. They actually have approval to provide those. That's good news. Workflow, we got a question about workflow. Who sends these? From a hospital perspective, it's always the nurse. The person who triggers this is the nurse that really works with the discharge information for the patient. In terms of receiving it into the hospital, we got questions about whether or not you would want to have multiple direct addresses for people to send to. And my suggestion on that one is that one is just plenty, and you need to agree on who's going to monitor it. My recommendation generally is the registration people are responsible, that department is responsible for triaging that, because a lot of what comes in are going to be orders for patients that you're going to be seeing soon, and they need to process those and get them attached to the correct patient, and then those messages still need to be available to the clinicians to actually post that information into the patient record. I appreciate that people want to say, oh, well, we'll have one address for surgery and we'll have one for OB and one for this. The problem is that your providers that are sending them to you are not going to know where to send them. So my best advice is just get one for the hospital and then work through the triage process. Over time, you may find that there's a legitimate and reasonable need for a special one. So one other question on this one. How are we meeting the electronic transfer requirements? It depends on what's in your community. One hospital was already connected to another hospital down the road because they were using the other hospital as a reference lab. So if you've already got that technical connection, hope the other hospital's on a different system and set up exchange for transition of care with those guys. The other thing is just pick your favorite physician practice. Anymore, a lot of the physicians have got electronic systems in their offices, and as long as it's different from the one that you're running in your hospital, you just really need one. Another challenge, downtime happens. It's not a matter of if, it's a matter of when. My best advice for you is to set up scenarios and actually have downtime drills with your systems. I'm just saying, I don't know that this is for everybody, but if you have physician adoption problems, I would very seriously consider having a drill in that area after you've had your system stabilized for 3 or 4 months and let the physicians enjoy trying to do work without the computer. If things go according to plan, they're going to be complaining to get that darn computer back up so that they can get their work done. Otherwise, it's going to endanger their patients. And when that happens to you, you can smile secretly and know that you have turned the corner with a physician adoption in that area. When we look at what really is at the root of the challenges with doing a lot of the meaningful use things, what we most often find is that it's either being run as an IT project, which is pretty bad since I'm an IT person, or it's being run as a finance project. This is a clinical initiative. It has to be owned by the clinical people with the finance and the IT people supporting them. If you don't have that governance in place that really has these people running these projects for the benefit of the patients and the folks who take care of them, you need to find a way to evolve your organization that way. For solutions, and we've touched on a couple of these things already, but I just want to emphasize them one more time. Get your clinicians involved. Talk about process improvement. Talk about continuous improvement for clinical activities. This really applies even with, and I'm flipping over to another area, but with ICD-10 where you've got to do clinical documentation improvement, it isn't going to work to go in and say, docs, we're going to teach you about how to improve your documentation for ICD-10, and we're going to show you how to do CPOE at the same time. Oh my gosh, if I was a doctor, I don't know how I'd deal with all of this. But you need to go in and say, okay, this month we're going to work on, pick an example, pneumonia, whatever your big DRG is. This month we're going to work on orthopedic post-op order sets. Next month, we're going to get that ingrained, and then we're going to move on to something else. If you set that expectation and they can clearly see that this is part of improving the way that medical care is delivered in your organization, you're going to get a lot more traction than if you try to do it as a one-time project. You need a quality council involvement in all of these things. And if you don't have one, you need a clinical leadership informatics committee. And I mentioned this earlier by reference. It may be small. It may be just a couple of doctors with some other leadership. For a smaller hospital, for a larger hospital, it may be a very large group with subcommittees for actually doing order set reviews and those sorts of things. But that is absolutely key to being successful with the technology. And not so surprising, it really is more about the humans and interaction and communication than it is about the technology. As an IT person, I know that we can make the technology work for us, and I also know that it will never be perfect. But I also know with the right people being focused on the right mission with this technology, you can be successful. We're seeing people all across the country who have been very successful with this. And I'd like to congratulate you because I know some of you are those people. So thank you very much. Just wanted to mention we hit a couple of these topics. These are the things that my organization can do for you. If we engage to help you with your situation, the first thing we're going to do is try to repair or improve what you have. We're going to look for workflow things that are going to make your clinicians have a better life every day when they come to work, help them improve their workflow. As a last resort, we're perfectly qualified to go through a selection process. We've got a pretty good understanding of what most of the products are out there in the market and what the price points are on those, what the pros and cons of them are, and we can help your organization through that kind of a process. Last but not least, I mentioned this. Sometimes if you have a hard message to deliver, we can be the facilitator for that conflict or for actually getting that message across. And then you can just shoot the consultant after we're gone, although we'd like for people to want us to come back. Also, I mentioned this once, if you have ICD-10 challenges, we have a pretty robust methodology for helping you create all of the deliverables that you need related to ICD-10. So I would enjoy getting a call from you on that. Having said all of that, I am going to share this back over with Kay, and we'll be ready to go.
Okay, thank you, Sharon. I just had a couple of slides I'm going to go through pretty quickly. We had quite a few questions about EPs and meaningful use. So I just put up some differences that there are. Their calendar year, not fiscal year like hospitals. We've worked with a lot of hospitals and their own physicians on their portal or their dashboard. So if you have any additional questions, feel free to call me and I'll be happy to help you.
Kay. I'm sorry to interrupt. Could you speak up just a tad bit?
Sure.
You're a little soft.
Okay, I sure will. Thank you, Amanda.
Thank you, ma'am.
The other question I'm asked quite frequently is how should we select our Stage 2 measures? There are 6. These are the 3 that we're seeing the most from our customers, but what I really encourage you to do is look at your numbers. What are the best 3 that you have? We had customers in Stage 1 that did all 10, and that was good for them. A lot of them rolled over for Stage 2, and they were more prepared for Stage 2, but that's just our recommendation. Also, CMS has an awesome Stage 2 toolkit. You can just go out on Google and put Stage 2 toolkit and find it. I have it bookmarked. I use it almost every single day, so it's a great tool. Sharon mentioned audits, and I will tell you we've had several customers contact us today that they got the dreaded email last night. So what you need to really watch for is it comes with a person's name. It also says the subject line is high-tech meaningful use audit, and it has an importance. So some people, this has gone into their spam. So whatever email address was given when you attested, you need to alert them. The email will tell you what they want, and there is a time frame. And by the way, I have that list of what they're requesting now. If you're interested, just let me know, and I'll send that to you. We've talked to hospitals that attested back in 2011. The person that did the attestation may no longer be at the hospital, and they have no idea where the backup proof is. So make sure whenever you attest, all of your backup is actually retained in 2 different places and backed up, because they can audit you up to 6 years from your last attestation. I also have a couple of recordings where different CIOs have presented about being audited. If you're interested in any of those playbacks, let me know. I could talk for 3 hours about patient portals, but just remember, if you're in Stage 1 in 2014, Core 11 and 12 are now retired, and you will have to do the greater than 50% of your patients have access. If you're in Stage 2, you get to do the 50% and the greater than 5%. And by the way, the ONC has issued some documents that are really awesome about portals. Be happy to share those with you. And we also offer consulting for portals, regardless of what vendor that you've chosen. So if that's something you need help in creating all of your plans and your marketing, let us know. I did put this slide in here just to remind you of what the timeline for your install is. CMS really recommends you have your portal live 2 or 3 months before the start of your reporting period so you can make sure you're meeting your numbers. Also, a lot of people ask me, if we have a community portal where we have the physicians and hospitals combined, is there an advantage? And so this is an FAQ that I've got available for you to tell you that you can count those twice, so that does help you. We also have a forum, an iForum on meaningful use. We have over 1,000 articles out there. You're welcome to join. It does let you know when we have new articles that are published. And tracking issues, just keep in mind, Stage 2 has made it a little more complicated. I've just outlined these. Core 1, the CPOE, has 3 separate measures you have to track. Core 5 has 2 yes and no's. Core 6 has 2%, and Core 12 has 2%, and they threw in a yes-no. So it is more difficult to track in Stage 2. And the other thing about CQMs that I'll share with you, I did a research. If everybody's probably heard of the Chapel, that's where all the certified products are. There was only one major vendor that certified all 29 of the 2014 CQMs. So check your vendors, see how many they've actually certified, because you want to make sure the one that you've selected has been certified by your vendor. One last thing I'll share with you is this is our dashboard that we do track. We are going to have a webcast on October 30th if you're interested in seeing that. We had some HIE questions, and we actually have an HIE expert on staff, so we've put his email address here for you and given you some resources. So any HIE questions, you can direct them straight to Rick Edwards. I will mention we are going to send this PowerPoint out. We have several questions in the chat, so I don't want to hold up any more time. Amanda, do you want to go ahead and read some of those questions for us, please?
Sure, I'll be glad to. Looking on the CMS guidelines, the calculations still say the denominator for CPOE is based on unique patients for Stage 2. We were instructed by our vendor that it was based on all orders. Can you respond to this?
Okay, this is Sharon. Do you want me to tackle that?
Yeah, you can, or we can both do it. Go ahead.
Yeah, I'm assuming that's the CPOE thing about the orders. And it is about orders. There was an option in federal fiscal year 2013, but with the beginning of October 2013, which is federal fiscal 2014 for hospitals, of course, you don't have any choice. You have to count orders, not patients. So that applies to the med orders, and for Stage 2, the lab orders and the radiology orders. Okay, if you heard that question differently, let me know. Take a swing at it.
Okay, well, it just, it says a unique patient in the reg. If a patient submitted to a hospital or emergency room more than once during the reporting period for the purpose of measurement, that patient is only counted once in the denominator. So there are some things, if you go through that regulation, you really need to read and come up with your understanding. I've heard about 10 different understandings of how people are reading that measure. So if you have any more detailed questions, let us know, and I can walk you through what I've researched. So I think that we'll get back with that person with more details as well.
Okay, and a question came in. It says, do you have a source for that stat? If you could just send me a chat message to which slide this applies to, and then we can get you the answer to that. In the meantime, the next question is, can you comment about clinical measures concerning zero qualifying? We are a small hospital and we do not keep stroke patients. They are transferred out. I was under the understanding that in Meaningful Use 2, you must choose measure that align with your patient population. Is that correct?
You want to go ahead, Sharon?
I'll start off, and then you can you can straighten us out. Well, high priority conditions for patients that are in your patient population, and you also have to hit, I believe, 4 of the 6 domains. So all of those things will affect what it is that you have to count. But I understand, I think we were talking about that earlier with one of the smaller hospitals. The thing that they're able to count because of the way the system works is not one of the things that they have a large population in their denominator. Having said that, I think that we still need some clarification. We're actually, and Kay, I'll be interested to see what you think about this. We're going around and around with a couple of other vendors and their experts about whether or not it matters how big your denominator is, that a zero denominator may actually be okay in your first year. The place where those exclusions really apply is when we start reporting electronically and we're sending in enough data for them to be able to see how big your population is. Because if you think about it right now, what's coming out of your system are actually your numerators and your denominators, but they're not going through and saying, here's what the original patient population was that was selected from. It's okay. Have you run into that, and how are you helping people buy it? I'm a little biased with some of the vendors that I've been working with. It's like, okay, I'm stuck with it, so that's what I'm going to do.
Well, a lot of our customers attended several sessions at HIMSS, and they came back with varying opinions about the zeros. One of the things I will tell you is that they are in stage 2, and well, of course, everybody in 2014 that tests, even if they're in stage 1, has to use the 2014 CQMs, number 1. Number 2, one of the reporting things that your vendor will be reporting now is your patient population, your IPP. So that is going to be going in, so CMS will be able to see, like you said, Sharon, electronically what your total patient population was compared to your scores. The other thing that has to be reported now when you report your CQMs is the payer, the race, the ethnicity, and the sex for all of your patients. Not on a patient identifier level, but as CQM whatever, you have this many patients that are this payer, this payer, this payer. So there's a lot more information that CMS is looking at to really help define the CQMs that you're reporting on. And again, not all vendors are doing all of the CQMs. There are 9 that are really, really bad. I'll just give you that. And if you want any more information, just let us know and we'll get you the more details. But I have customers doing both ways. One say we only need to add 1 more CQM, we feel good. I've had others that are going to add 4 new CQMs and remove 4 from the original 15 because they feel like their patient population demands that they do different CQMs and not have 0 balances. But on the critical access side, it's really a tough challenge.
Okay, we have a couple minutes left with a couple questions here in chat. CQM certification is a calculation certification, correct?
It's a calculation of the numerator-denominator, and there's also a certification for electronic submission. So when your vendor goes and is tested with their testing partner, they have to test for each of the 29 CQMs. So when you go on the chapel, it'll tell you, go to the second page of your vendor, it will tell you which CQMs they got certified for. Now, the chapel hasn't been updated since September the 27th, so it could have had some of them who may have updated. I know in the Meditech world, they did 20. They say they're going to do the other 9. Like I told you, the nasty 9 is what they're being called. So really check and see what your vendor's gotten certified for and make sure that's one of the CQMs you're selecting, because it's not like it was in stage 1.
Okay, and real quick, what is the chapel?
The chapel is the Bible. If you just put in CHPL in your search, everybody that's attested has gone to the chapel. That's where you go list all of your certified products. It's like going to a shopping cart. Then it gives you your Medicare ID number that you need when you attest. So it's looking to make sure all the vendors that you're using have the certified solution for that particular need that you're using them for. So if you need any instructions, I have a PowerPoint I can send you that walks you through how to go through the chapel.
Okay, and we have 1 minute left. So stage 1 audits were mentioned. Do you have any statistics on hospitals passing versus failing?
I can tell you. Oh, go ahead, Sharon.
Yeah, well, I was just going to say, I don't have any statistics. All of my information is anecdotal.
Yeah, and I've only heard of a few. There's nothing published yet. I've only heard of a few that had to refund their money. But now they're auditing 1 out of every 20 provider. That includes EPs and EHs, and they're doing prepayment audits. So you may attest, and they come back and audit you before they ever pay you. And again, I've got that documentation of what they're asking for now. Anyone that wants it, we can send it to you.